In today's video, I had the absolute pleasure of speaking with Dr. Rahi Victory. Dr. Rahi Victory is a globally renowned Canadian-trained obstetrician gynecologist with an American board of obstetrics and gynecology subspecialty in reproductive endocrinology and infertility. Dr. Victory is renowned for his compassionate, individualized patient plans and approach to care. His extensive experience combined with an avant-garde approach provide a unique experience with unparalleled results. Dr. Victory and his fertility team focus on a holistic approach addressing traditional medical approaches, complementary medical approaches, and even surgical approaches with expert-level, minimally invasive gynecology experience. Dr. Victory shares his knowledge freely, hosting the most viewed online live fertility program on multiple different platforms, helping thousands improve their experience and success worldwide. Dr. Victory is passionate about making sure every experience is an exceptional one, and to that end, he meets with every client, every egg donor, and every surrogate himself. Dr. Victory's principles are science, technology, communication, compassion, and above all, honesty. Dr. Victory's only goal is your success and satisfaction. Before we jump into today's video with Dr. Victory, if you haven't already, please like this video, share with a friend, and subscribe to the Endo and Fertility Space channel. Now let's get to today's info-packed interview.
Well, thank you so much for taking the time. This isn't in real time. It's not live. So for viewers, this is a Saturday evening. So look how incredible and generous Dr. Victory is with his time. Thank you so, so much. I appreciate you. One of my first, actually, my intro to you was through a client who had only wonderful things to say about you. And then when I started to dig into your content and learn a little bit more about what you do, I was pleasantly surprised to see you have sort of a unique, refreshing approach and perspective on fertility, infertility, ART, and that sort of thing. So I'm really, really happy and honored to have you chatting today. So thank you so much.
Thank you for having me. I'm the one that should be honored. Your following is huge and you're doing great work. So I'm very excited to be here.
Right back at you. So I thought it would be appropriate just to, introduce yourself. Who are you? What do you do? What makes you a great person to chat with about fertility, assisted reproductive technologies, IVF, hormones, all the great things we're going to chat about today.
I'm Dr. Rahi Victory. I'm a Canadian trained and board certified obstetrician gynecologist. When I finished my training in Canada, I went to the US for an additional 3 years of what I now refer to as slave labor. And I became a reproductive endocrinology and fertility specialist. And so I'm now actually board certified in Canada and the US for both.
Amazing.
And when I started out initially, I guess I have to admit I was very much kind of like everybody else, did my thing, kind of stuck to the basics. But years ago, we realized there were some really kind of unpalatable things going on in the fertility world where treatments were being offered that didn't have any evidence or reason behind them. It seemed to be kind of mainly financially motivated. And I don't believe in that at all. I believe in doing the right thing for people. So we started our show. And when we started the show, it really forced me to constantly read. And I think through that process, I became a better fertility specialist and then really learned how far we can take this when we really listen to patients, focus on what's actually wrong, provide them with information and education, and then let patients choose. And because of the knowledge, we get to try some really kind of avant-garde techniques and protocols. And I'm a huge believer in sort of customized, personalized medicine. I find all too often these days it's very cookie cutter medicine. And the minute you walk through the door, they just say IVF. And, most patients don't even know what's wrong. So I wanted to kind of flip the script and say, why don't we actually find out what's wrong? And then let's talk about what the options are for fixing what's wrong. And then let you choose based on being educated and informed. And so that's kind of who we are and what we're passionate about.
I love that. And that's why I'm so happy to be chatting with you because you are so refreshing. You're unlike a lot of other, I mean, I don't want to say anything negative, but like it's a reality, like right, like what you said, right? Often very financially motivated. I don't know if you feel comfortable speaking to this, but you had mentioned that you saw a couple things that didn't really sit right with you. Could you give an example of something like that?
Oh yeah, I mean I've got them on our YouTube channel, so they're out
So
there.
go
I'm
there.
comfortable.
Watch
Yeah.
those.
So the initial reason for this show was I kept seeing people doing double IUIs.
Mm,
So they would do an IUI and then 12 or 24 hours later they would do a second one.
mm,
And and I knew the evidence for it. There were six randomized controlled trials, and this is going back many years now, all of which showed absolutely no benefit to doing it. So patients were being charged double or close to double, but they weren't getting anything out of it. And so we actually started our very first program based on an article that showed that there was no benefit to doing this. And so from there, it really just kind of took off. I mean, there are loads of things like this. So we get patients now that go into the clinic and they're told that they're 38, so they need IVF. Well, why is that true? I mean, age is not a diagnosis, right? So that to me seems absurd. Like, what's actually wrong with the patient? You ask them because they'll come to me for a second opinion, and they actually don't even know what's wrong. They were just told it's your age. Or people that have unexplained infertility. There's multiple options for unexplained infertility, but all too often they're pushed into IVF. And so, again, I just always felt like, why aren't we doing a better job at just being doctors? Like our job, our duty, our obligation is to provide answers and information and educate patients, give them options, and then allow them to choose. But because there's this like business overlap in our world, that is unfortunately more and more taking
mm.
the center stage. And so I think it's compromising patient care. And nowhere is that unfortunately more true than where we have now the intersection between venture capital and private equity and fertility, right? So many of the clinics throughout North America and really the world now are owned by businesses.
Mm.
So their goal is financial. It's not medical. No matter how much they may advertise or promote that they're invested in the patients, they're invested in being successful. And those two things don't always go together. You know, sometimes we do procedures for free because patients need it or they're desperate or whatever.
Yeah,
You can't do that when you're running a financial model. So
right.
that was really kind of where it sprouted from and kind of as on an ongoing basis, we keep finding new things all the time.
Yeah,
So
that's
yeah.
incredible. You also had mentioned that the whole idea of like unexplained infertility.
Yeah.
Would you say that the preliminary investigation that you do when a new patient comes to you, would you say that that's, comparatively to maybe one of these clinics that is a little bit more motivated by finances? Do you think it's like a little bit more comprehensive, a lot more comprehensive?
Um, I think we probably all are fairly similar in our initial investigations. So
Okay.
most people will do blood work, hormones, vitamin levels. I do vitamin levels. I do a
Yeah.
detailed thyroid evaluation because I know that's critical, including antibodies. Maybe that doesn't always get done. Pretty much everyone's doing either a hysterosalpingogram or a saline infusion sonohystogram. Obviously, male analysis as well, sperm testing. We offer sort of next level testing where we're evaluating things like in the males, hyaluronic sperm binding, which shows you how many of the sperm are mature. We have a device called Myoxis, which measures the amount of oxidative stress or reductive stress in the ejaculate. We have female testing that we kind of go into more detail with things like vitamin D. Obviously, many places are doing AMH. We focus a lot on the shape of the uterus, the size of the uterus. Is it T-shaped? Is it Y-shaped? And then I think the biggest one, which obviously is critical, with your background as well, is we very much focus on the chance that the patients have endometriosis. So in Canada, it takes on average 5 years to be diagnosed with endo from the time that you walk into your doctor's office and you say something's wrong. And in the UK, it's 7 years. So we as physicians are doing an abominable job at actually listening to patients. And so I listen. I mean, heard that loud and clear, and really from day one said to myself, like, this is a big part of our training. Why are we not hearing our patients when they say, I have pain, I have uncomfortable periods, intercourse is uncomfortable, or even just I have unexplained infertility? 44% of those patients will have endo. So
Mhm.
we really focus on making sure we look for answers. And even when we can't find them, we have even more advanced testing that we offer, looking at the microbiome or gut health or looking at immunological aspects of infertility. So I think we're willing to go the extra mile, but the initial kind of testing and evaluation, it's pretty standard across the board. Once you have those, you sit down with the patient, you say, you have this wrong or that wrong, or I didn't find anything. So we can either go further in testing or I can offer you these treatments.
Amazing. I think that's a really nice segue into my next question. I wanted to chat a little bit about, you had brought up endometriosis. Obviously, that is my niche. That is the population that I serve. So
Yeah,
I wanted to chat with you about how endometriosis affects fertility.
sure. How many hours do we have?
I know. Let's do like a short version.
So, generally, when I'm talking to patients about this, to sort of break it down for them, I'll tell them that endo has multiple different effects on infertility.
Yeah.
So, there's a direct effect on egg quality. We know that because there are many studies demonstrating that. Probably the best of them is that in patients who are using a surrogate, but the patient themselves has endo, you're not getting the same quality of embryos as you are from someone that doesn't have endo. So there are decreases in success just based on egg quality, fertilization, blastulation. So there's that kind of direct impact on the eggs. And then we have sort of a mechanical impact often as well. Damage to the fallopian tubes, damage to the ovaries, scarring, adhesions, a lot of inflammation that goes along with that. And so it can actually functionally block the ability of the sperm and the egg to meet or to travel down the tube or to implant in the uterus. And often endo and its twin evil sister adeno go together. And so now you have implantation issues, miscarriage issues, all of those are increased. And then finally, of course, we know for sure that your immune system, being a hopefully reasonable immune system, recognizes that these cells don't belong there. So it'll go into attack mode. And in attack mode, it is trying to kill off the endo or the adeno. The problem is, as good as the immune system is, it's not particularly discriminate.
Yeah.
So when you get an embryo in there and you've got these sort of immune soldiers in attack mode, they're just shooting. They don't care if it's, friendly fire or not. So anything in their way gets taken out, and oftentimes that's the embryo. So you've got this massive over sort of response of the immune system. And as a result of that, it can really um, sort of affect or prevent the embryo from either sticking or staying stuck because miscarriage rates are higher with endo patients.
Yeah. Gosh, I have so many follow-up questions to that. I'm curious with endo and adeno. I don't even know if this is a fair question. It's a bit of like a sideball, but how, and I don't even know if this can be differentiated too well, but like how often are you seeing recurring losses stem from adeno and endo versus like an immunological cause?
I'm not sure I could answer with great knowledge about the percentages between immunological versus adeno endo. What we do know is that endo patients have higher rates of miscarriage. They
Mm.
also have higher rates of aneuploid embryos, we believe. The data is a little more controversial on that, but I am a believer that endo patients make more genetically abnormal embryos. So those can both lead to miscarriage. And then adeno for sure. I mean, the data on that's very clear. Your miscarriage rates are higher.
Mm.
How much of it is a mechanical impact versus an immunological? I don't think anyone knows the answer to that or even could. But as I mentioned, there are studies that show that even if you take the embryo from an endo patient and you put it into a surrogate, their risks are still higher for loss or failure. So there is some impact directly on the embryo. whether it's from the egg or the embryo altogether, that you're not getting rid of simply by switching location.
Yeah. But like for example, having like a high amount of natural killer cells or some kind of like bizarre ratios in your immune cells, that could be a separate issue, right? Or you could have that coupled with endometriosis or adenomyosis, or you could be somebody who has these abnormal ratios or a high amount of natural killer cells and then not have adeno or endo, correct?
Yeah, that's absolutely right.
Yeah.
So immune problems can be independent of endo and adeno. However, all endo adeno patients have some degree of immune dysfunction. So, for example, in our program, when we're treating patients who have endometriosis and we are doing IVF for them, we have a customized, dedicated endometriosis protocol, one part of which is just using an immune protocol. So we use things like intralipids, steroids, and
Gosh, I love that.
one of the drugs that's really helpful now is called sirolimus or tacrolimus. It's also known as rapamycin because that's been
Mhm.
shown to have quite a significant impact. A couple of weeks ago, I found some research saying metformin is also beneficial from an immunological perspective. So there are things that you definitely can attack to reduce the inflammatory nature of the endo. And by quieting that down, it definitely will improve your chances.
I love that. And I want to dig into that in a moment. But I did want to ask too also about the causes. Do you see hormones play a big role in contributing to infertility or subfertility in endo patients?
Yeah, for sure. I mean, our diets are terrible, as you know better than I do. And we're exposed to a lot of artificial substances and
Yeah.
foods, processed foods.
Mm.
So I think it does wreak havoc with the diet and the gut and our hormones and reproductive health. From the standpoint of exposures to estrogen, of course, things whether it's coming from a food source or obesity. On my drive over here, they were saying 80% of Americans are overweight. I mean, that is just staggering, right?
Yeah.
Like, that's terrifying as a statistic. So, the reality is that whether it's coming from your adipose tissue or from your diet, or even if you're being exposed to it directly from a medication standpoint, there's no question that high levels of estrogen are going to make your endo worse. One thing I frequently get quite frustrated over is we've got these fertility clinics who are doing what we call hormone replacement therapy cycles for their IVF patients. They'll bring them in, they know they have endo, and they're putting them on 2 milligrams of estrogen or 4 milligrams of estrogen several times per day, twice a day, 3 times a day. These people are developing these sky high estrogen levels, and I always describe that as pouring fuel on fire, right? I mean, it just makes no biological sense. And I remember presenting to an entire Canadian clinic. I'll politely keep their name, aside, but I was presenting to them and I said, like, is this what you guys do? And they said, yes. And I said, that makes no sense. And literally, no one had sat down to think through the fact that, yeah, that actually doesn't make any sense. Why are we doing this? And
Yeah.
so I'm hoping that we can start getting people to think about ways to keep the estrogen levels low so that you're not inflaming the immune system, you're not activating the endo. You want to keep everything nice and quiet so that the embryo lands in a nice, happy home and says, hey, this is a good place to implant.
Exactly. Yeah, well said. I'm happy that you were there to educate the medical professionals in that clinic. Okay, I want to go back to some things that you already kind of started to allude to a little bit, but I get a
Sure.
lot of questions around specific IVF or ART protocols for people with endo, like special considerations. I think you're an amazing person to ask. So you already kind of alluded to like intralipids and tacrolimus. That's how you say it, right?
Yeah.
Um, so yeah, I'd love to hear some sort of general thoughts about that. I mean, naturally, these protocols need to be individualized, I'm assuming, right? But just generally, are there certain things that you find to be a little bit more effective? Maybe endometriosis patients who are going down their fertility journey should know to ask about, or maybe just default and come to you because you're awesome.
So I guess I would start by actually beginning on your end of things, which is I think things
Oh,
like diet,
love that.
vitamins, health support is a critical foundation for the process. A lot of clinics, a lot of patients think that once they, utter those three letters, IVF, that they're cured, that the problem is solved. But the reality is, if you go into an IVF cycle with bad eggs or bad sperm, you're going to have a bad outcome too. And
Absolutely.
so I think optimizing the starting materials, the building blocks is critical. So we actually do spend a lot of time talking to our patients about their overall health, eliminating toxins, smoking, drinking, drug use. Eat healthy, don't eat the processed foods. Make sure you're on multiple different endo-fighting supplements, things like NAC, curcumin, resveratrol, ALA, coenzyme Q10. So we focus a lot on making sure our patients enter into their fertility treatment optimized before they even begin. So I think that's like the critical foundational aspect of it. Once you're into stim, a lot of endo patients have weaker ovaries. And so many clinics will give them very high doses of stimulation medications. If it's the gonadotropins like Gonal-f, Menopur, Recavel, these types of drugs, Puragon. And we aggressively avoid that because we know that I always say it's a very good way to make me rich and a very good way to make patients poor because it just basically fries the eggs for
Mm.
all intents and purposes. And now you have no more eggs than you would have if you had used a lower dose. But the quality of those eggs is definitely compromised. And there is data to support that. So we try and keep the doses of what we're using reasonable. So I don't think you want to underdose it, and I definitely don't want to overdose it. You want like a medium protocol. And you also don't want to go for a long time because, again, you're exposing these patients to high levels of estrogen. So if they can't produce enough eggs within sort of 10, 12 days of stimulation, you actually have to tell the patient this just isn't working. Stop. I know there's one clinic that has patients that go, 16, 20, 24 days. You're never going to get good egg quality from that. Never. It's impossible. So, you're just pouring fuel on the fire every single day. I mean, that's never going to have a good outcome. And those are the patients that come out of it and say, wow, like my pain is worse, my periods are worse than ever. Our intimacy has become really uncomfortable because you had someone actually doing damage. So
Exactly.
that's like the stimulation part of things. From the frozen embryo transfer standpoint, I really do think it requires a very dedicated protocol. So we suppress our patients first with Lupron and Letrozole, which basically annihilates the estrogen levels. I do fully respect the fact that I am torturing women when I do this, so my apologies to anyone that does
Oh.
it. But it is necessary in order to mitigate the effects of the endo. And there are now three separate studies looking at that, all showing benefits. So we follow the science. Once we're getting to the point where we're ready for the lining to develop, we try and avoid any estrogen. If we do use estrogen, minimal, like 1 milligram, 2 milligrams max per day. And then we know that endo patients are progesterone resistant, so you need higher doses of progesterone. And many places don't monitor it, but we do. We actually measure the levels to make sure that we're above that threshold that you need to be. And then we enter in the immune protocol. So we really want to address the endo holistically so that we've got it from every aspect that we can.
Amazing. Do you use immune protocols with all endometriosis patients?
Yeah.
For the most part, yeah. Okay. I did want to ask too, like with the Lupron suppression, how quickly after the person comes off the Lupron are you timing a transfer?
So we actually the Lupron we use is a 3 month dose usually, although we've altered that for certain people that don't want to wait that long. But we typically will go 3 months
Hmm.
and 95 days of letrozole. And as soon as your letrozole is done, you're rolling into your cycle. So you're getting ready for your transfer as soon as the letrozole is finished.
Okay. Any concerns over the lining after suppression for so long?
There are some people that don't respond. For
Yeah.
sure. And so for those patients, what we say is don't do anything, wait for the next month. Your
Mhm.
body's going to flip back to normal, but the effects of the suppression will last at least a few months. So, reactivating your hormones is not an on-off switch. It's a very gradually activated dimmer switch. And so you've got some time before the estrogen exposure will fully reactivate your endo.
Amazing. And just for listeners, for anybody who doesn't understand, what is the benefit of the letrozole?
So, two things. One, Lupron basically turns off the signal in your brain to produce estrogen,
Yeah.
but letrozole prevents the rest of your body from doing it because we, in men and women, produce estrogen in our adipose tissue, our fatty tissue, and so you want to really take care of both elements, not just the ovarian source and the adrenal source. You also want to take care of the peripheral sources too. So. The letrozole helps you do that, and it basically turns everything completely off. And the funny thing for me, well, I shouldn't say funny, but the strange thing for me is that many fertility centers will tell patients to take Lupron before doing a frozen embryo transfer if they have endometriosis. But Lupron alone has never been shown to be beneficial.
Oh,
It's
wow.
actually useless. So you're torturing the patient because you're putting them into menopause, but it's not menopause enough to actually benefit them. And so you really need that letrozole to show a benefit. Even worse is that many patients are on the antagonist like or Alyssa or Myfembree, and those don't even have the benefit of Lupron. And there's zero, like there aren't even any studies evaluating that for endo patients prior to frozen embryo transfer. So when patients tell me, oh, my doctor suppressed me with this, I'm saying, well, no, actually they didn't, because it doesn't keep your estrogen suppressed enough. So yeah, there's a lot of misinformation, miscalculation, and I mean, I don't want to say it's because of malintent or anything on the part of the doctors. I'm hoping it's just ignorance, but I
Yeah.
kind of hold myself to a higher standard. So I feel like
Yeah.
if I'm ignorant, then I'm disserving patients, right?
Yeah. And I think if you have an understanding of the way these meds work, it's just it's logical. It makes sense to
Yeah.
pair letrozole. Yeah, totally. And I wanted to ask to always frozen embryo transfer with endometriosis patients.
Yeah. So not always, always, but mostly always.
Yeah,
So
I think it makes sense, right?
yeah. So if you've produced more than, say, three or four eggs, your estrogen levels are going to be very supra physiological. In other words, way over the normal levels of estrogen in your
Mm,
body. And so again, we've poured fuel on the fire. So when is the worst possible time to do an embryo transfer? Right after I really made your endo aggressive and
exactly.
made your immune system particularly inflamed in its attempt to turn off or fight the endo. So that's always going to be a fresh embryo transfer. Now, if you only made one egg, like we do natural cycle IVF for some endo patients, or you made two, your levels aren't high enough to really cause a major problem. So in those cases, you can say, okay, you're still in good shape. We got a beautiful fresh embryo for you here. Let's go for it. But as a general rule, if you're making several eggs, your estrogen levels are too high. It doesn't make any sense to do fresh.
Yeah, that's logical. That makes sense to me. Okay, I want to change gears a little bit and get your thoughts on surgery pre or post stimulation. Do you have an opinion on this?
I do. I do. So it's very interesting. The fertility world discourages patients from doing surgery in general. Um, I, I have my suspicions as to why. I think it has to do with delays in patient care,
Mhm.
and lack of access to the patients. And then, of course, if you look at it from a very cynical viewpoint, lack of getting the patients to spend money in your clinic.
Sure.
Um, the science is quite clear that if you have surgery and you have endo, you do better. There's no question about that. The problem is that if you have cysts of endometriosis and you remove the cysts from the ovary, you do diminish the ovarian reserve somewhat. The
Yeah.
cyst itself diminishes the ovarian reserve by about 40%, and removing it reduces the ovarian reserve by about 40%. So you're kind of damned if you do, damned if you don't.
Mm,
So, what I generally tell patients is this. If you want to try to get pregnant without doing IVF, and probably preferably IUI, although IUI, your estrogen levels never get that high. But if you want to avoid IVF, you're someone that wants a natural approach, you should do your surgery first because we know it almost doubles your success rate. It's going to help you with pain potentially. You're going to get rid of a lot of adhesion and scarring and damage. And so now you're actually going to have a much more robust, healthy, natural outcome and chance of success compared to what it would be without this surgery. Excuse me. If you are thinking of going down the IVF route, the problem is every time you do your IVF cycle, you're making your endo worse because here come your high estrogen levels. There's your stim for the endo. So in that situation, you want to bank all of your embryos. So make as many embryos as you think you need before you go for surgery. Then what we typically do is we suppress the patients, which helps quiet it all down. Then you operate on them while they're suppressed, which A makes the surgery safer and easier, and B probably a bit more successful. And then you roll right off that suppression into the highest chance of having a successful outcome from a frozen embryo transfer because you've suppressed them and you've operated on them.
Mhm.
So it really depends on what the patients want. If they want natural, do the surgery first. If they want to do IVF, you really have to do the IVF first because the worst possible outcome is you do the surgery and then the patient decides, oh, now I want to do IVF, and you do 2 or 3 rounds of IVF. You just potentially brought back all the endo you just treated.
Mm.
And you don't want to be operating on people a lot. That's not a good idea.
Yeah, yeah. I totally agree with that. It's very logical. I don't know how recent the study was, and I don't know, I mean, it is a study, but from what I've read, if the ovaries are operated on,
Yeah,
then the AMH does end up climbing back up to pre-surgical levels within a year, which for
that's
some people
correct.
is a really long time, right, to
Yeah.
wait. But maybe another little consideration if somebody has a little bit more flexibility with their schedule, with their time, their timeline.
Yeah, no, that's very accurate. That study you're referencing is 100% correct. And
Yeah.
actually, there's a meta-analysis on this where they showed that the number of follicles that you have doesn't actually change. It's actually
Oh,
just
okay.
the AMH level and your FSH levels that change. And they do return to normal usually within 6 months to a year. So, I'm not a believer in telling patients don't operate. I give my patients the option.
Hmm.
So again, if they want to have IVF, we generally speaking will do the IVF first and then do their endo surgery. But I do encourage them actually to go for the surgery because it's going to improve their
For
chances.
sure. Yeah, there's quite a large body of literature that speaks to that, right? I don't know if this is an appropriate question, but do you find that your endometriosis patients tolerate your protocols well for the most part? I know it's a tricky question, but they sound so much better than what I've kind of heard anecdotally in conversation with patients who, seek out fertility care in clinics that maybe don't have endo-specific protocols.
Right. Um, so I'm not going to pretend that I'm not torturing these women. Uh,
Yeah,
I feel like I'm asking a lot of them.
for sure.
Um, I do our protocols out there. It's published. It's on our YouTube channel. We talk about it all the time. I don't hide any of this stuff. And I get at least 1 or 2 messages per day from people globally who have had years of infertility, struggling with endo, and then they found our protocol. I've never even met these people before often, and they used it and they messaged me saying, "We used your protocol and we now are pregnant." So I
Wow.
think those stories help get women who have to struggle through those 3 months of torture through it because they know that on the other end they're going to have a better chance than they would otherwise. But listen, I don't pull any punches with this. I tell all the men I have a spare bedroom and I tell all the women, please forgive me. Like, this is rough. It's a very unfriendly thing to do to somebody because
Sure.
you really are robbing them of their hormones suddenly. It takes a week and then they're fully suppressed.
Mhm.
So think of you today, Saturday, being perfectly fine. And next Saturday, you've got hot flashes, night sweats, mood swings, vaginal dryness, sleep disturbance, and decreased sex drive. Like it's not it's not going to be enjoyable for sure.
Mhm.
So I
But
warn patients before we do it to them. And thankfully, you can salvage it if it's too severe by giving patients either some progesterone or, low dose estrogen and progesterone back. But that defeats the purpose of the protocol.
right, the suppression.
Yeah.
And I mean, like you alluded to, if you do it one time and it's successful and then your transfer is successful, then you're not stuck having to do repeat stimulations.
Right.
And that's ultimately at the end of the day so much better for the
Right.
endo, right?
For
One of
sure.
the things, one of the things that I felt was so different about you and why I definitely wanted to reach out and make sure I got you on the channel is that, you're one of the first people, if not the first person who advertised and encouraged Fertylisis testing
Yeah.
and sort of this kind of I should say unconventional sort of approach to infertility and subfertility. So I'm curious, how have you used the Fertylisis testing in practice? Have you found it helpful? Do you find that there's a lot of applicability of the testing to people who have endometriosis?
Yeah, so I actually was turned on to Fertilsis before it was Fertilsis. It was a different company originally.
Okay.
And I got turned on by a client of mine, and she told me about it. And I said, "What is this?" And she told me, and I said, "Let me check this out." And I immediately thought, "Wow, this is great. We can do a lot of good with this." And in her case, she had had a very long, arduous struggle with infertility. Part of it was endo, and so we managed to use the Fertilsis to help her. This then kind of opened me up to the whole world of microbiome, gut health,
Mhm.
vaginal health, uterine health, and of course, immunological based reproduction or infertility. So, what we initially did was we said, look, if we have patients that have had, a very limited number of embryos, like they only have one good embryo, or patients that have failed multiple embryo transfers, we should start investigating them with this to see if we're missing something. And last summer at the Canadian Fertility Show in Toronto, we did research on our data up to that point.
Mm.
So at that point, we had had 49 patients that we had had either a very limited number of embryos or they had failed more than two transfers. And so we took those patients and we had done Fertilsis testing on them. And when we corrected whatever the problem was, whether it was microbiome or immunological, and then did a transfer, 91% of those patients got pregnant
Wow.
when we tried
Incredible.
again. And
Incredible.
so that number was staggering because I've never heard of anybody getting a number that high in any venue whatsoever. So that was really surprising for us. We weren't expecting it to be that high. And the other thing is that these are patients that are compromised and they're getting that number. So these are the sort of poor prognosis patients where you're anticipating you're actually going to do worse. These are the ones that get the 20%, the 30%. And I feel like jumping off the Ambassador Bridge here in Windsor. But the reality is, we were getting numbers you can't get even when everything is perfect. If I brought a completely healthy couple, young, healthy, no fertility problems, and I did IVF on them, you're going to get in our program probably about an 85% chance. 91 was higher than even them. And so we knew we had something really amazing there. And so we've stuck with it and we have a great relationship with Fertilsis, but it really does make an enormous, enormous difference.
Yeah, I agree for sure. I'm not super, super well versed in Fertilsis testing. Like I've done some of the testing myself. My husband has done some of the testing too.
Yeah,
I know they do they'll test like the uterine environment with the menstrual blood sample. And I do think that they measure some of those immune cells right within the uterus. And then there's like
yeah,
the vaginal swabs. And then you can also submit a semen sample. And then they kind of break down if there's any bacteria in there that might be causing inflammation or affecting the health of the sperm.
right.
So if you get like an abnormal swab result, for example, how do you act on that? How do you intervene on that with a patient?
Yeah, so we use a combination of antibiotics, probiotics. We now have a whole protocol for this because we've tried a couple of different ways. There are some patients that are actually extremely difficult to treat. The bacteria don't want to go away. So it's not very well known, but many bacteria form something called a biofilm,
Mhm.
which is a protective blanket that doesn't allow them to be killed just by taking antibiotics.
Yeah.
And as you can well imagine, delivery of antibiotics into the uterus is not great.
Mm,
It's very difficult to get antibiotics in there.
mm,
So you have to actually break down the biofilm first, and then you got to kill them with the antibiotics. And while you're doing that, you got to replace the bacteria with good bacteria. So we use boric acid to hopefully dissolve or attack the biofilm. We use antibiotics that are targeted for each bacteria, depending on what you have. And then we use very, very high potency probiotics to flush the good bacteria back into the system. Plus diet. And from a nutrition standpoint, one thing I recently heard from a family doctor, we couldn't actually get her microbiome to settle.
mm,
And she contacted me and she said, I finally fixed it. And I said, what was it? And she said, I went on Ozempic. And I said, what? And she said, yeah, because when she went on Ozempic, it helped her with her weight. Once her weight went down and her diet improved, her gut health improved. And because
mm.
her gut health improved, it somehow translated into the bacteria and the reproductive tract as well. And there are some studies that show that your gut health will reflect or your uterine health, I should say, will reflect your gut health. So I
Yeah.
was like, wow, I mean, this could open up whole new doors. And not that I'm promoting Ozempic, but
Yeah.
I think it's a fascinating concept and something people will start looking into over time.
Yeah, absolutely. And you're probably not referring to endometritis alone when you're saying when you were referring to that resistant bacteria or infection, right? It's like a broad
Yeah,
collection of
so
bacteria.
endometritis is a pathological diagnosis. In other words, the guys that didn't want to see patients and just wanted to see tissue as physicians, they're looking at slides of biopsies,
Mm,
and they're analyzing it and saying, we have these many, white blood cells, typically CD138 cells. And if you have more than six or eight, whatever their diagnostic criteria are, you have this diagnosis of endometritis, but it's actually completely meaningless
oh,
because you can have adverse bacteria waiting to go on the feeding spree when an
mm,
embryo lands there, and they will not demonstrate endometritis because they've learned to just kind of hang around and lay low until such time as they need to activate and influence what's going on. And so that's why a test like Fertylisis, where they're actually doing PCR of the bacteria, is infinitely more valuable because you're actually seeing what's there and what's not there rather than do I have manifestations of what's there or not there. So many people, for example, with ureaplasma don't have any endometritis, but if you've got ureaplasma, it's extremely difficult to get and stay pregnant.
mm,
So that's
mm.
why we use this kind of testing to avoid that sort of problem.
Wow, interesting. I did not know that with ureaplasma, it's hard to get and stay pregnant. It's very,
Yeah, so animal studies show very clearly that it decreases success and increases
wow.
miscarriage rates. We suspect it's the same in human beings, and certainly I can tell you, having seen what happens with the Fertility patients, we have all these patients that have had years of infertility. You do the Fertility test, you find out they have ureaplasma. You treat
Mm,
them, you eradicate it, and then many of our patients actually get pregnant before they even have to do IVF.
naturally.
Because they're actually resolving the core issue, right? The root cause is addressed, and now you don't need to spend 12, 15, $20,000
Yeah,
to get
incredible.
pregnant.
That's great. And I know that there is a body of literature around the vaginal microbiome, right, and the uterine microbiome and the effects of that on success rates, and having healthy levels of lactobacillus strains is very protective for fertility and reducing inflammation. So
Right.
yeah, this is what I was referring to when I'm saying it's so refreshing to be able to connect and chat with a doctor and a fertility specialist. Gosh, it's late in the evening. I cannot get my words out. Who has this, unique, refreshing approach that I feel like should be, universal. And I'm sure you get wonderful results as a result. And I'm sure all of your patients are so grateful to you. Thank you so much.
Thank you.
I
Really
absolutely
appreciate the opportunity.
Thank you so much for tuning into today's video. Please don't forget to give this video a thumbs up if you learned a thing or two, and please don't leave without subscribing. I'll see you in the next video.